is not stopping the drug abruptly because you can get side effects. So there's a withdrawal syndrome. It's not, it'll make them feel bad. It could give them symptoms. It'll make them symptomatic. It could appear as a worsening of the underlying problem. It could be a worsening of depression or something else. So it can muddy the waters in terms of following them and determining their response. So here are the symptomatology. On page 12, if you look at the bottom, general somatic symptoms are common. So those lethargy, headache, tremor, sweating, anorexia, it's often referred to as a flu-like syndrome. So they'll feel like they're coming down with the virus. At the top, the sensory symptoms, paresthesias, numbness, electric shock-like sensations that they will get in their body, rushing noise in the head, the palinopsia or the visual trails, that gives you kind of a picture of them with that hand movement, disequilibrium, lightheadedness, dizziness, vertigo. Next page, they can get more irritable, mood changes, anxiety, agitation, weepiness, tearing, and then GI symptoms, nausea, vomiting, diarrhea. Sleep disturbances can also occur, so on page 14. So there's a little mnemonic for these symptoms called FINISH. So flu-like symptoms, insomnia, nausea, imbalance, sensory disturbance, hyperarousal. So one of the pharmacokinetic factors that you can take advantage of is that fluoxetine, because of its very long half-life, tends to have less of those withdrawal symptoms. So if you had someone who was a little bit non-adherent and missed doses, even though I don't like to choose drugs on that basis, this one will tend to have fewer discontinuation or withdrawal symptoms compared to the others. If you have to take someone off of an antidepressant, it's better to taper them off over a 1 to 2 week period. If you will cut the dose slowly over that period of time, then these symptoms are likely not to occur. Any questions on those? Okay, SNRIs, the serotonin norepinephrine reuptake inhibitors. So the advantages here is you are affecting two different neurotransmitters. So for some people that may be more helpful, may be more efficacious for them. On the downside is that you now have two different systems that you can then have side effects from. The old products, amitriptyline, abemperbine, doxepine, nortriptyline, desipramine, these are all now generic. Still have their uses. We use amitriptyline for the neuropathic symptoms, especially in the feet that people have. I don't know why that came on.
It did it to me. I was just standing up here in advanced slides 3 or 4, so
Oh, really?
It's doing some weird stuff today.
Okay. We don't use these products as much on a large scale because of their side effect profile. They also have much more devastating effects, particularly cardiovascular in overdose situations. They can be deadly taken in a high enough dose. They also have a lot of side effects that are more anticholinergic related. So amitriptyline, the TCAs tend to have a very high incidence of anticholinergic effects. And then their cardiovascular or adrenergic side effects, orthostatic hypotension, they really do mess with the electrical components of the heart. So arrhythmias, conduction disturbances, AV blocks are also what you'll see usually in overdose. You don't see it with just dosing it normally for depression. Desipramine is a little bit different in that it has been known to cause sudden death, cardiac death, particularly in people that have a family history of dysrhythmias. So that's the old products. So let's look at the newer. So the newer products are venlafaxine and desvenlafaxine. So desvenlafaxine is the active, one of the active metabolites of venlafaxine. There's duloxetine, which is really a very different drug from the rest of them, but also fits into this category. And then there's milnacipran and levomilnacipran. So levomilnacipran is the levo isomer of milnacipran. So these drugs affect serotonin and norepinephrine, but they will do them, some of the drugs will do it at different dosing intervals. So at low dose, they're mostly serotonergic, and as you increase the dose, they become serotonergic and adrenergic. Some of them are both at the very lowest doses and throughout the dosing period. If you look over on page 16 at the bottom, you see with venlafaxine and desvenlafaxine that the serotonergic effects are much, much greater. So if you look at the little picture, they're showing you receptors, the drug sitting on it, the red, or the pluses, since you're in black and white, some of you, the 5 pluses on the side, that's telling you that serotonergic is dominant, and on the right-hand side, the little 1 pluses are the norepinephrine or adrenergic. So 5 times more serotonergic than adrenergic. So the serotonergic side effects are going to predominate with those 2 agents. If you look on the next page, 17, it shows you that venlafaxine at low doses is serotonergic, at higher doses it has dual activity. But if you look at desvenlafaxine, it's the same across dosing. So this becomes important from a side effect standpoint because of the different affinities of that drug for the different receptors as you increase dosing or change dosing. Okay, so now I'll go back to the first part again. Go back to page 15 again. So under mechanism of action, we talked about venlafaxine, desvenlafaxine, and milnacipran. You see that it's a potent inhibitor of norepinephrine and serotonin, but it's 3-to-1 norepinephrine to serotonin. And the levomilnacipran is predominantly norepinephrine. So this class is really different. The SSRIs were fairly consistent with some effects on these other neurotransmitter systems. For this group, they are very different from each other. So in this one, it makes more sense that if you do not get a response to one, is moving to another. Okay. On top of page 16, duloxetine, I told you is really different. It's serotonin, norepinephrine, and it does have effects on dopamine, but at a very low extent. And then I've just, in that next bullet, their affinities for serotonin, norepinephrine, I've just given you another restatement of what we've just said in terms of serotonin, norepinephrine effect. So in terms of the kinetics, these drugs do not interact with the 2D6 as much as the SSRIs do. But the one to keep in mind is duloxetine. It tends to be a more potent inhibitor than the others. The other 4 have very low interaction with the P450 system, so their interaction potential is low to non-existent. So that one will be something to keep in mind that you can use to your advantage for patients who are on drugs that are metabolized through that system. The SNRIs, as are the SSRIs, I don't think I specifically stated it, but if you are going to, if a patient's been on a monoamine oxidase inhibitor and you're going to move them to an SSRI or SNRI, then you have to wait at least 2 weeks. You never, ever use those class of drugs together. Okay, and why would that be? Go back to this. What is that monoamine oxidase inhibitor doing?
Breaking down serotonin.
It breaks down serotonin, and so this is going to be around a lot longer. Then what if you put in a reuptake inhibitor in that same person?
Too much serotonin.
Too much serotonin. So the bad thing that can happen is the serotonin syndrome, and we'll talk about that in just a bit. So never use those together, and you need a washout period, at least 2 weeks. Allows this enzyme to recover before you start a SNRI or an SSRI. Same thing if you're going the other direction. If you are moving them from an SSRI or SNRI to a monoamine oxidase inhibitor, you're also going to wait a 2-week washout period. Okay. Adverse effects, so move over to the bottom of page 17. The 3 most common with this class are nausea, which can be significant, dizziness, and diaphoresis. So the nausea is most problematic at the very beginning. Venlafaxine XR has the lowest incidence. Desvenlafaxine has the highest, and it's one of the primary reasons why people stop taking it. If you look at the next page, blood pressure changes. So the more these drugs affect norepinephrine, the more likely you're going to have changes in cardiovascular status. So if you have people who have conditions like heart failure that's not well controlled, history of stroke, TIAs, high risk, already have blood pressure that's not well controlled, avoid these drugs. Because their effects on norepinephrine will raise their blood pressure. With the exception of duloxetine, which has very little effect on blood pressure. So that's one in that class that you can use. As we saw with the SSRIs, sexual dysfunction with the SNRIs is also high. Venlafaxine XR has the highest rate of sexual dysfunction in this class, and desvenlafaxine has the least. For milnacipran and levomilnacipran, the predominant effect is on norepinephrine. So here, think about your adrenergic contraindications. So the cardiovascular is one, end-stage renal disease is another. Avoid using these patients in patients who have glaucoma. This would be also true for the SSRIs, is avoiding them in patients with narrow angle or closed angle glaucoma. These drugs will worsen urinary hesitancy, but they are weight neutral. So for men who are having trouble with BPH, you wouldn't want to use these drugs. You have someone who is very worried about weight gain, then your SSRIs that are going to cause high weight gain, then this would be a drug to consider. Okay. So there's great advantages here in that you have drugs that all are efficacious to the same endpoint, but the side effect profile is different, so you can more match. So it's hard to have a go-to drug. Well, I'm always going to go to this one. Well, that may work. But knowing where to go when it doesn't work or when people complain is the art of using the medications with this knowledge. Make sense? Venlafaxine probably has the highest increase or incidence of bleeding disorders associated with it. Again, it's not that they think the drugs cause bleeding. It is their effects on serotonin and platelet aggregation that's going to cause the most problem. And again, these are on the Beers criteria. Okay, the next two classes of drugs are the atypical. So the norepinephrine and dopamine reuptake inhibitors. This is on page 19. There's only one in this class, and this is bupropion. I don't know why they make these so hard to say. We saw this one before in smoking cessation. It's called Zyban. So it's marketed under the name Zyban. So when what the drug companies do is they will get a drug out on the market, and then they either know from their other testing or as they're developing that drug that it probably will have other indications. Once they get it out there, then they will file a new drug application for a different indication. They will often give it a different name. So they can market it under that name, or they can market it under Wellbutrin for depression. Now, there's some advantages to them doing that, because early on people knew that this drug worked well in smoking cessation. But if you prescribed Wellbutrin, it wasn't an FDA indication for smoking cessation, the insurance companies would reject it. And then what happens is the person gets labeled with the use of an antidepressant. So that can cause trouble for some folks in terms of getting other insurance down the line. So often, I don't always point it out, but occasionally we'll have drugs that will have two different names, and that's the reason why you've got two different major indications that they're going for. Often they're dosed pretty much the same. There isn't a lot of difference there. This is unique. This is a very different antidepressant. It's rarely used by itself. So we don't use it to treat depression alone. We usually use it to augment other therapy. So if you have an antidepressant that maybe is working well, it's fairly well tolerated, but you're not getting maximum effect, instead of changing to a different drug, you can add this one on. It is not very common that we use two different antidepressants to treat. But we do have these two, mirtazapine and bupropion, that we can use to augment therapy. It's very good if you have patients who are responding depression-wise to a drug, but their sexual dysfunction is not tolerable or something they're willing to put up with, then bupropion tends to ameliorate that, so you can add that on. Side effects. Insomnia, very predominant, to the point that you need to not dose it late in the day. It's usually dosed twice a day, or you can use an extended release once a day. If you do an extended release, it always needs to be in the morning. If you do a regular release, it needs to be in the morning and then about mid-afternoon. I found that it worked best if I had the patient never take it beyond 2 or 3 o'clock in the afternoon. So maybe 8 and 2 is what I would recommend folks to do. So insomnia is significant and common. The other is that this drug lowers the seizure threshold for patients. So it can precipitate new seizures in folks. If you use it in combination with other drugs that lower the seizure threshold, you can precipitate new seizures, or you can worsen an existing seizure disorder. So those are the two important ones to remember. Seizure impact is also related to dose. The others, dry mouth, dizziness, anxiety, tremors, those are more common, but they're usually not drugs that cause them harm or that cause them to quit necessarily taking the drug. It does have some contraindications that are worth paying attention to. because sometimes the use of psychotropics is indicated for these disorders that are listed there. Eating disorders, bulimia, and anorexia, this drug should be avoided. Also in abrupt withdrawal from alcohol, benzodiazepines, other sedatives, because they also are seizure provoking. Questions about that drug? Useful one to keep in your pocket until that you can bring out as needed. The other atypical is on page 21. This is mirtazapine. It is serotonin and adrenergic, alpha-2 blocker. Rivarol. Another unique antidepressant. It also can be an add-on to other agents, other therapy. Have to be careful though because it is a serotonin agent. So the side effects, if you look down, it does have weight gain is one of its major side effects, like we saw with paroxetine, and very commonly occurs when used. Dry mouth and drowsiness are another common complaint that we've seen with others. It does not cause a change in sexual function, so one to keep in mind if you have patients that cannot tolerate the others. Doesn't have any effect on blood pressure, no cardiovascular effect. I put a rare in there for the agranulocytosis and neutropenia because it's so odd compared to all the other agents. It doesn't require outside or regular monitoring of white blood cell counts. Just something to keep in mind if it should occur. Not a very common one used, but it can be part of your arsenal.
Dr. Latasi,
Yes.
did you say does not increase sexual dysfunction?
It doesn't. Let me check myself. Just a moment.
That's what it said.
Yeah,
Yeah, I thought you
but,
said a decrease.
The last of the big groups are the monooxidase inhibitors. These drugs have been around forever. They were around when I went to pharmacy school. Special phenelzine and tranylcypromine or carmate in Nardil. Not used as much because of the drug interactions and the food interactions. They have a lot of side effects with them. The other one that is in there is selegiline. We just talked about it with Parkinsonism. Remember, it was an MAOB. We took advantage of that as part of our treatment, or as an add-on to the levodopa or the dopamine agonist. The most common side effect is hypotension. You'll remember that when we talked about it with Parkinsonism. All others are weight gain, sexual dysfunction is similar to the others. Some differences in the group though, phenelzine tends to cause sedation, whereas tranylcypromine is a stimulant or an activator, so it can cause the insomnia, fever, jerking motions, or increase in deep tendon reflexes. The one thing most people know about MAOIs is avoiding tyramine, because it's a precursor to the neurotransmitters, and so you can get great increases in norepinephrine. So these folks have to be educated about avoiding drugs, food with tyramine in it. And I've given you a list down there. You need to know some of those. Some of the big ones, people usually know cheese. Avoid cheese. Wine is another one. Beer, the same thing. Others more common, like fava beans, have become more popular in the recent. Other cheeses you see listed there, chocolate, there's no way I can take that drug. Not my chocolate. In coffee, those are my two staples, coffee and chocolate. So those you would need to give a handout. There would have to be a lot of patient education about doing that because it can be serious. They can die from the hypertensive crisis it can precipitate. Questions about those? I will write you out a statement about which ones are to know because you don't have to memorize the whole list, Blake. Probably anybody eat liver in here?
Yeah.
I love liver. Chicken livers, chicken gizzards, fried, they're so good.
Yeah.
Well, we go with the Nicks and the Sticks, what I always get. Fried chicken gizzards. They're so good. Okay. Next page, the last are the serotonin modulators. They're not used very often, but they are a class that can be tapped into. They are also extremely diverse members of this class. They're kind of loosely put into this class called serotonin modulators, but they all are very different from one another. Probably the one that's used the most common in this is trazodone. Trazodone came out, it was one of the first agents that came out after all the tricyclic antidepressants. It's not that great as an antidepressant, but it's a very sedative drug. So people use it more, prescribe it now for sleep. It is about 60 to 70% of people are made so drowsy they'll go to sleep. So it's often used as a sedative. Let's see. You'll see nifazodone is pretty much serotonin. Trazodone is alpha adrenergic, so you get some hypotension with it. Histamine, sedation. The other two, vilazodone and is a serotonin reuptake, but the other one is a serotonin reuptake. It's a serotonin reuptake inhibitor. It's much more like the SSRIs, so very, very diverse. So in this group, nausea is the major problem, sedation, and dry mouth. Again, more I'm just telling you to be aware of them. I don't even know where to tell you in therapy to use them unless you have gone through the others and you don't have patients who can tolerate or use them. On the next page, 23 and 24, I made you a table of the side effects. You can take this and use it however you want. It pretty much reflects what I have in the text for you in terms of common drugs or common reactions to a class, and then I've got the individual. Just for time, I'm not going to go back through the summary or the washout because I'm just repeating what I've already said. Treatment of resistant depression. Resistant depression is thought to be primarily due to inadequate treatment of a depressive episode, probably due to non-adherence or just ineffective treatment. When it occurs, the things that we've already talked about would be changing dose, changing the antidepressant, the class, or using it or augmenting it with the therapies we've talked about. Any comments or questions up to this point? Okay, let's talk about serotonin syndrome. It's an important one to remember because it is a medical emergency. It is something they could die from. So it's very important to avoid multiple drugs that have serotonin mechanisms. That's the problem that's the reason why most of the time it occurs. So there is a criteria called the Hunter diagnostic criteria. Have you been introduced to this before? No? Okay. So 2 ways to diagnose this syndrome is, have they taken a serotonergic agent? If they have not, then it cannot be this. So have they taken a serotonergic agent, and then do they have one of these 5 groups of symptoms? So a serotonergic agent and one of these symptoms, clusters of symptoms. So spontaneous clonus, inducible clonus and agitation or diaphoresis, ocular clonus in agitation or diaphoresis, tremor and hyperreflexia, hypertonia and temperature and spontaneous or inducible ocular clonus. So there is a pattern there of muscle symptoms and diaphoresis and usually an autonomic dysfunction. So common drugs that are serotonergic, can you think of ones we have talked about to this point? Pardon? Cocaine is one of them. Codeine, I don't know.
Oh wait, I thought if you mix codeine and antidepressant can cause the serotonin syndrome.
Oh, I don't know. Maybe. You got
I
me.
thought we discussed it in our respiratory.
Let me go back and look. I don't, codeine in particular? Oh, let me look.
Respiratory depression.
Suppressants.
Cough suppressants, dextromethorphan, yes, because it's an amphetamine-like drug, yes. So that's true. So your amphetamines, your cocaine, dextromethorphan, so you want to ask about over-the-counter products. What did we just talk about in headaches? What are the big migraine headache drugs?
Triptan.
Triptan, so they have serotonergic effects. Metoclopramide, we've talked about. Some of the anticonvulsants, valproic acid.
Zofran?
Zofran is an antagonist, so we might use it as a rescue. Right. Okay, if you look on page 26, you've got a picture of what someone might look like who has serotonergic syndrome. You see the diaphoresis. They can be just drenched in sweat all over. Mydriasis, how would that happen? How's mydriasis happen? So what muscles control the size of the pupil?
Ciliary muscles.
So you have a radial, right? If you can contract it and pull it back, the pupil gets larger. That's under adrenergic control. The other one is under parasympathetic control. So you have serotonin receptors in that area of the eye. And so when you have a lot of serotonin around, you get it's like a mydriatic, so you get a mydriasis. You see the agitation. You see the autonomic dysfunction. You've got tachycardia. You have diarrhea that can occur, hypertensive. They can have clonus. The tremors, the clonus is usually lower extremities, hyperreflexia. I gave you a table there at the bottom because we'll talk about, when we get to the antipsychotics, we'll talk about neuroleptic syndrome. So these syndromes can look very similar, but they have very different causes and they have different manifestations. So we're focusing on that second line of serotonin syndrome. Muscle tone rigid, skin is wet, moist. Pupils are increased, vowel sounds increased, reflexes increased. So this is the way you can discern it from the other manifestations. Malignant hyperthermia can occur during surgery with the inhaled anesthesia. Neuroleptic malignant syndrome are antipsychotics. And then anticholinergic toxicity is in there as well. So treatment is really supportive for the most part. If you look over the next page, you want to get rid of any serotonergic drugs. So remove the cause is really important. Supporting all their vital signs, so their heart rate, temperature, if need be. They're using benzodiazepines can be used to relieve the anxiety. You can also use cyproheptadine, which is a serotonin antagonist. It's usually not used in mild cases. Usually removing them and supporting them will allow them to clear the drug and the syndrome will resolve itself. For more moderate to very ill patients, you may have to use something like cyproheptadine. So you can see in the middle there, supportive is oxygen, IV fluids, monitoring, correction of vital signs. For severe hypertension going down, using like short-acting beta blockers like hezbollah, or you could use nitroprusside, that's your big gun in terms of controlling blood pressure. For hypotension, if it's related to a monoamine oxidase inhibitors, you see different drugs. You see pressors there, phenylephrine, epinephrine, norepinephrine. The hypothermia doesn't usually respond to like Tylenol or nonsteroidals, so those are ineffective in this case. So using cooling blankets or other means to lower their their temperature. Usually getting their muscles to relax will go a long way in helping that. So using that sedation or benzodiazepines is also important. And then the cyproheptadine, which is more of an antihistamine effect, but it has anti-serotonergic agents as well. So it can be sedative like most antihistamines and can lower the blood pressure. So that might be a problem for some. Questions about serotonin syndrome? Okay, what have you, so that's unipolar. What have you learned about bipolar disorders? Disorder.
They have a manic side to it. That's pretty much how we would diagnose them with the type 1.
Right, they have a manic phase, acute, or it can be chronic, and then they have a depressive phase as well. What else?
And type 2 and hypomania instead of a true manic.
Okay. How do you tell the difference between acute mania and hypomania?
Acute, they cannot function, like they have to leave their jobs and stuff. Hypo, you can pretty much keep going.
What kinds of symptoms go along with that? What's an acute manic?
Ideas of grandiose. So
Ideas what?
like grandiose ideas.
Yeah, very grandiose.
Big,
Okay.
high energy.
Yeah, yes, high energy.
Can be extremely irritable.
Extremely irritable. Okay. Did you show them a film of, did you do a film? Pressured speech. Stream of ideas. I had to interview one time when I was a PharmD student. I could not get out of the room. I don't think I talked for 30 minutes. It's just that stream of consciousness coming at you and blowing you away. Very interesting. What else did you see in the film of the person?
Irrational decision making,
Yes, so how might that play out?
just in life in general,
Yeah.
could really put them in a bad spot.
Yeah, money-wise could be violence, okay,
Hallucinations.
hallucinations. So they can have a psychotic symptoms along with that. Did you look at hypomania? What would hypomania look like?
Less severe, it doesn't cause you to, you can still go on with life, and it's usually only like 4 days instead of a full week.
Okay, so less time, less intense. They're usually fun people to be around, I think. What else?
Once you receive the diagnosis of bipolar disorder, you can never go back to like a major depressive disorder, you'll always have that title.
Okay, good point. Anything else? Very good. Very good. Okay, so in our treatment, our goals are to One is to keep them out of that acute and manic side. Actually, to just keep them from fluctuating, to more even out their moods. Prevent further episodes, maintain good functioning so they can keep their job, maintain their social contacts, their work and their play. Promoting treatment adherence. Did you all talk about difficulties with the mania or hypomania with adherence to therapy?
Sometimes they like that feeling.
They
of the high.
do, they do. And so it's hard sometimes to get them to take their drug because they feel like they are somebody else. It's what I've heard them say is that, well, when I'm on that drug, I am not myself. Even though to people around, you're different and maybe more able to engage them, but it really is a deterrent for them. And then with other, like we talked about the other psychotropics, is minimizing their adverse effects so that they will hopefully be more adherent. So treatment is individualized, just like we saw with the major depressive disorders. Long-term adherence, and so these folks are on lifetime agents.
Did you have a parent delivery?
Dr. Britton.
Not that I know of.
She's-
yeah,
it's
Is it,
The
are y'all
lunch.
doing a lunch thing?
Yeah.
Okay. That's fine. I just forgot they put, I know they were doing a little midday thing.
Okay.
Yeah.
So patients should be on mood stabilizers, and they'll be on that all of their life. When they have acute episodes, you will add drugs, and as they stabilize, you will taper and take those off. And for the depressive episodes, we're going to treat it very similar to what we did with the unipolar. The non-pharmacologic therapy is take care of yourself, just like we tell everybody, sleep well, eat well, get your exercise, keep stress down as much as possible. Using mood charting can be very helpful to them and also to you as a practitioner to detect early signs of depression or mania. They may be, did you talk about rapid cyclers? Okay, so what are rapid cyclers? Okay, so they go up and down a lot versus those that aren't. So you want to decrease those rapid cycling episodes. And then psychoeducation programs or counseling for the family, if need be, for the patient, certainly, to help them maintain those relationships. There's several guidelines that are out there for the treatment of mania and depression. The one I pulled for you is CanMet. I thought of all of them, it was the easiest one to follow, but there's others that are there as well. And I can post those on D2L for you all to download and use. Medications for the treatment of acute mania are, let's go to the bottom then, is lithium is very commonly used, very hard drug to use, lots of side effects. The anticonvulsants, valproate and carbamazepine are used as mood stabilizers. And the atypical antipsychotics, you'll see SGA there, second generation antipsychotics is what that stands for. We'll talk about those more on Thursday. So aripiprazole, olanzapine, quetiapine, ziprasidone, risperidone, all of those are in that category. On the next page, maintenance therapy for bipolar is lithium and the anticonvulsants. So what we're going to see as we walk through those tables is we are going to use one or the other is going to be used, either lithium or valproate, and then we're going to add drugs. We may use them together, or we may add other agents to them, like the atypical antipsychotics. Quetiapine or Seroquel is the only drug that has FDA approval to be used as monotherapy. The rest of them are used in conjunction with those other agents. And then in an acute manic, lithium is the drug of choice. Okay. Let's walk through this and then I'll show you how to use these. I pulled these tables from Hanmac. And I'll show you which ones I want you to use. So I have the information is duplicated several times, but this shows you flow. If you go down through the steps, look on page 31, it may be easier to use. Here are the steps for the treatment of acute mania. So assessing the cause, discontinuing the antidepressant, taper off the stimulants. Caffeine is a big one you will see in here mentioned as a drug that should be removed or avoided for patients who are manic. Encouraging the good nutrition, exercise, the sleep, the stress, the psychosocial therapy. So those are your step one. First line therapy is to optimize the current mood stabilizers. So that could be valproic acid, carbamazepine, or lithium. Or initiate a mood stabilizing agent if they're not on one. The second is to add on therapy, which you'll see from the tables, or switch. And then you do that at the fourth step and then the fifth step. We're just going to concentrate on the first and second line drugs. So if you look down in the first table is acute mania. So I want you to know the monotherapy and the adjunct. You do not have to know specific drugs, but you have to know the class. So for with the adjuncts under the first line, it's primarily you're going to use lithium or valproic acid with a second generation antipsychotic. That's what all of those are. Under monotherapy, you're going to use lithium or valproic acid, and again, an antipsychotic. The second line is carbamazepine, Haldol, which is a first generation antipsychotic, and then or a combination of lithium and valproic acid. That's what I want you to know. The rest of the third and fourth line, you don't have to know. So I'm gonna end here because we're coming up on lunch. But again, this on page 30, that flow, if you follow it through, is the same thing that I have repeated at the top of page 31. And the chart is referring back to those first and second line is actually in that step 2. So step 1 is more, what is the problem, what's precipitated it, what's aggravated it, generalized non-pharmacologic, and then step 2 starts the drugs. So first line, second line aren't referring to first step, second step, they're referring to what do you do in that step 2. Okay. Questions? Okay, well, I'll stop there and I'll pick it up with acute depressive disorders in bipolar. And then we'll talk about lithium on Thursday. All right, have a wonderful lunch. Do you want me to rewrite the objective?